So we've already heard from Amita and Gagandeep about the vaccines. So once we have a vaccine that is approved either for emergency use or for regular use, for use in public health program, there are certain considerations. I've listed 5 of those here, and in the next slide, I have tried to elaborate those. In the vaccine, one needs to look at safety and efficacy, as Gagandeep talked about. This efficacy can be for preventing death, can be for preventing serious disease or disease of any kind, mild, moderate, or severe. There could also be efficacy in preventing transmission by decreasing the excretion of the virus from those who are infected. Logistic issues that one needs to look at is the number of doses, 1, 2, and for some vaccines that could even be 3. And storage and transport, again, that has been talked about earlier. Some vaccines need to be stored at -70°, -20°, making their delivery challenging. The volume needed also becomes important because that impacts on the cold chain space that one would need for rolling out a particular vaccine. Because this disease affects certain specific age groups more severely, the elderly, and also is more severe in people with certain pre-existing disease conditions, one needs to look at efficacy in specific subgroups, that is in the elderly and in those with comorbidities associated with severe COVID. Cost of course is a consideration, and the amount available has to be looked at in relation to the requirement of a particular country or community. So when we look at vaccine rollout in India for public health purpose, we, with our 1.3 billion population, are looking primarily at reducing the burden of disease, in particular, the need for ICU care, and to reduce mortality. Interruption of transmission, that is achieving herd protection, would need coverage of a large proportion of our population. Let's assume that that would be somewhere between 60 to 70% on a conservative scale. Even then, the amount of vaccine needed would be so much that we cannot think of that today. There are countries that are thinking of that approach. Israel, for instance, has already immunized 1/3 of its population, which is on a totally different scale. Same way, UAE has immunized about 1/4 of its population, but we are not looking at that. We are looking at reducing mortality and hospitalization and reducing the social impact of the pandemic and having our economy go ahead. And we do this realizing that there are several knowledge gaps in our understanding of the disease and the vaccine. We do not understand how long the immunity lasts after natural infection, what proportion of our population in different parts of the country has been already infected and is potentially immune. We do not know the efficacy of the vaccine in the specific subgroups, at least for some of the vaccines, and we do not know the duration of protection afforded by the various vaccines. So, as I said earlier, ideally, if the vaccines prevent transmission, again something that we do not know, then everybody should get the vaccine. Even if they prevent severe disease, everybody should get the vaccine. However, production capacity is limited, so we need to prioritize the vaccine for some groups over others. WHO's Strategic Advisory Group of Experts on Immunization has developed a values framework about how limited supply of vaccine should be allocated and what groups should be prioritized. And these are based on very well laid out principles that we respect in medicine, and also ethicists respect these. The first is that we want to maximize human well-being, and that means it should be given to those who are at a higher risk of severe disease, coming to harm and death. It is based on principles of equity, global equity, national equity, equity for groups that are downtrodden, equity for the rich and the poor. The next principle is reciprocity, which means people who are contributing more to the global good, to looking after people with COVID, to preventing COVID should be given preference, and that's where the preference for healthcare workers and other frontline workers comes from. And finally, all decisions should have legitimacy, which means these should be taken transparently. So this is the WHO's prioritization scheme. It is based on, as you see in dark blue, the different stages, which mean how much of population can be covered with the available vaccine. Stage 1, when vaccine is available in very short supply, covering about 1 to 10% of population. Again, that is divided into 2 stages, as you can see, 1A and 1B, depending on whether we are close to 1% or 10%. Stage 2, when vaccine is available to cover up to 20% of population, and stage 3, when even greater large quantities of vaccine are available. So in stage 1, healthcare workers who are at a high to very high risk of acquiring and transmitting infection to their patients are to be immunized. Then come older adults defined by age specific based risks. So these would be the very elderly. And then come the other groups. In India, the various groups that are looking at COVID-19 vaccination strategies. So the COVID-19 working group of the National Technical Advisory Group on Immunization, as well as NAGVAC, which is the multidisciplinary cross-cutting group beyond Health Ministry that is looking at policies for immunization for COVID, have decided prioritization based on similar principles. The first recipients are people who are at a high risk of exposures. That is the first responders. Again, within that, healthcare providers in health facilities and those providing field level healthcare services are the first ones to be covered. And that started on 16th of January, that is about 2 weeks ago. The next group, which will be receiving the vaccine beginning next week, are going to be other first responders, such as people who are in the police, who are helping implement non-pharmacological interventions such as distancing, masks, etc. And the municipal workers will get at this. And then we will go to those who are at a high risk of poor outcome. That is initially those with age more than 60, and later age group between 51 to 60, and those with younger than 50 who have comorbidities. The number of healthcare workers in the private and public sector with our 1.3 billion population was estimated to be about 1 crore, and that is the first group. And of these, to the best of my knowledge, about 30 lakh have already been vaccinated. The next group, the other frontline workers, are going to be about 2 crores, and the age-based priority groups, those more than 50 years of age and those younger than 50 and having comorbidity, are estimated to be about 26 crores. A total of about 30 crore people are planned over the next 1 year. Prioritization for vaccination is one part. In addition, we need to ensure supplies. There is a lot of logistics involved. So vaccine has to be procured at a reasonable price. It needs to be transported, and in our country with its large geographical area and different topography, we have a lot of transport challenges. That has been done by the Ministry of Civil Aviation. Storage facilities are needed. So those that needed storage at -70 or -20 were not suitable. That's why we have vaccines which are suitable for storage at 4 degrees. Cold chain equipment have been beefed up, and supplies for 0.5 ml auto disable syringes have been procured. Just imagine 30% of our population comes to about 30 crore people needing vaccination. You need 60 crore syringes, and that's a huge challenge to procure them. We have taken decisions, and delivery mechanisms have been put into place, and mechanisms to monitor for occurrence of adverse events following immunization and their management have been put into place. However, there are new challenges. Vaccine hesitancy is something that exists around the world. In terms of definition, it is defined as delay in acceptance or outright refusal for taking vaccines in spite of their becoming available and their being available at one's doorstep. Reasons for vaccine hesitancy are multiple, they are complex, they are context specific, and they vary with time, place, and the vaccine. World over, three major factors have been thought as influencing vaccine hesitancy. These are related to convenience. Is the vaccine available close to you? Do you need to pay for it, etc.? Complacency of the potential recipients and the confidence in a particular vaccine. Fortunately for us, in this slide, what you see is the proportion of people who believe that vaccines are safe in different WHO regions. And if we see, that is India, it is surpassed only by Bangladesh. There is a very high 97 to 98% belief among people that vaccines are safe. So we should have had very little vaccine hesitancy. However, vaccine hesitancy, as I said earlier, varies with time and vaccine. When a disease is at its peak and a vaccine comes in, people want to take vaccine coverage increases, and the disease frequency comes down. And that is when people enter a sense of phase of complacence. Now, people start losing confidence. They don't think vaccine is needed because they think disease is going away. Vaccine coverage comes down. It is followed immediately by increase in disease. Again, people start believing in the vaccine. With this resumption of confidence, removal of complacence, then the disease gradually disappears. Also, adverse events do play a role in people losing confidence. And what is happening in India is we are actually somewhere here. So the vaccine has come in when the disease has decreased drastically. So we are starting with a phase where people seem to feel nothing is going to happen. We can relax, read our newspapers, be easy. We don't need to take the vaccine. And that seems to be a major factor, particularly among healthcare workers. And it is somewhat disconcerting because they have seen disease. And surely it is at play because of 1 crore people who were eligible, only 30 lakh have taken vaccine. Also, this may have to do with our failure of communication. The other challenge that we have today is the SARS coronavirus variants that have come in. All viruses, their genome changes over time, in particular for RNA viruses. Fortunately, SARS coronavirus, though an RNA virus, has some proofreading ability, and so the mutation rate is somewhat intermediate. Now, variations are all the time, but they may have no consequences. Sometimes the virus has the similar characteristics, except that it has survival advantage. So the variant strain replaces the original strain. But what we are bothered about is when a new variant has a higher transmission rate, has a different in the propensity to cause severe disease or death, or if the new strain would not be neutralized by the antibodies to the wild type strain or to the vaccine strain. So let's look at SARS coronavirus 2. It has a single stranded linear RNA genome, which is about 30 kilobase long. It codes for 29 proteins. A large part of the genome codes for the various non-structural proteins. There are 4 main structural proteins: the spike protein or S protein that you heard Amita and Gagandeep talk about, envelope protein E, M, and N. When we look at the viral particle, the N protein or nucleocapsid is in association with the RNA in the center, but there are 3 proteins on the surface: the spike glycoprotein or S protein, the E protein, and the M protein. Of these, the S protein is the most important. It exists as protrusions. It's a trimeric protein, 3 molecules joined together to form this. And this is the protein which is used by the virus to bind to the hosts, to the receptors on the host surface, cell surface. And then it is internalized and the viral nucleic acid is kept carried inside the host cell. So the protection has to come by antibodies directed against this S protein. And that is what we use for the vaccine. So this is when we started last year, somewhere in January 2020. There were 2 different type of isolates that were circulating in China. But by the time the disease reached Europe, we can see very variant types of virus appeared. These 2 shown here in green and yellow were the ones prevalent in different parts of Europe, and the one in blue in somewhat of maroon color is what was seen in the US. The 2 dark and light blue isolates, which were the predominant isolates in China, gradually died down, and it is clear that these green and yellow strains were actually present in very small quantities in China, and it is those that preferentially got transmitted, or those were the ones that were carried early in the outbreak to Europe, and that's where they spread and they became predominant. Some new isolates have appeared over time, as you can see over time. In the upper slide, what you have on the x-axis is the number of mutations. But every time a new isolate came, it varied by 1 or 2 change. However, what suddenly happened in December, a new isolate was detected, which was different from all previous isolates, suddenly by several nucleotide changes. And this is the most varied mutant that has been seen till today. Finally, even though it appeared between November and December, we can see a rapid increase in its prevalence in southeastern UK over a period of 2 months. This is what raised concern. And the other thing was that if we compare it to the wild type coronavirus genome, the genome of this isolate had 23 mutations. 6 of these were silent, but of the remaining 17, 9 were scattered all over, but 8 were in the spike protein, including 2 deletions and 6 substitutions. This meant that the spike protein of this variant in UK, known as B117, could be very different from the original strains. And of these 4 changes that I have highlighted with a box are particularly important. Let's first look at this mutation called N501Y, which means at the 501st amino acid in this protein, asparaginase is replaced by a tyrosine. So when we look at this, as Gagandeep said earlier, this is a trimeric protein. So in each of the 3 molecules, this undergoes a change. So this is the part that interacts with the receptor, and now the binding of the protein with the receptor is relatively feeble. But once you get this change, the interaction becomes stronger, and this variant virus can now bind more strongly to the host cells and is more infectious. Similarly, 2 other changes are located in these projections of the protein, one on this side and one on this side, and it appears that these deletions of 2 amino acid each in the protein make the antibody less likely to bind to the spike protein, and therefore antibodies are less likely to be effective. A 4th mutation is somewhere here, and this again alters the protein to a significant degree. The other way to look at this is that this isolate has spread globally. The areas in black showing where local transmission is also occurring, and those in purple showing areas where imported cases have been seen, the local transmission has not yet been shown to occur, but I think it's only a matter of time before we would have that. We have this isolate in India too. Several cases have been reported. And in each region, so this is 6 curves are for 6 WHO region, for 6 continents, and in each continent where it has appeared, over time, the proportion of cases accounted for by this variant are increasing rapidly. This variant has a higher rate of transmission, is more often associated with severe disease, and in the next slide I'll show you some data that show that it is not as susceptible to antibodies against the usual SARS coronavirus. So this is a paper that has appeared as a preprint, and this takes sera from people who have been immunized with the Pfizer vaccine. This is the data with the wild type virus neutralization, and this is with the variant neutralization, and we can see that, and this is using sera from multiple vaccine recipients. For each of them except one, the serum from the vaccinee could inhibit the wild type virus much better than it could inhibit the UK variant. So, and this is the average. So we see that the amount of antibody needed is about threefold higher for this variant virus to be neutralized. A second variant has appeared in South Africa. This was first reported in the third week of December. This is again seems to have a different clinical features. It affects predominantly young person without any comorbidities. Two mutation, one the same as the UK, but another one that seems to be important is at position 484. This strain has also traveled to several countries in Africa with local transmission shown here in black, and to other parts of the world. Yesterday, one case has also been reported from the US, which is not shown here as colored. Again, this has increased rapidly from October by January in Africa, and is making appearance in other continents where we think it will increase again. Now, this is a study again in preprint format that appeared earlier this week. They took plasma from people who were affected during the first phase between June to August 2020 and used it to neutralize virus isolated from people affected at that time and people affected in South Africa now. They added this plasma in different concentrations. With increasing concentrations, one would expect that on culture you would see inhibition with increasing plasma concentrations. That is with the first wave virus. If you increase the virus concentration, you can see the growth is very little. These are two strains from the variant strains from two patients, and we can see even with the same concentration that inhibited the first wave virus, this virus is not inhibited. This is done with one person's plasma, and that is shown here. If you see, for some of the infected person's plasma, there is no inhibition whatsoever of the South African isolate. A third isolate in Brazil, isolated from Manaus in October-November 2020. It has some of the same mutations that are seen in South Africa, but has some more mutations. And the biggest challenge here is, in Manaus, there was a huge outbreak, somewhat like what we saw in India, between April to June. In October, it was estimated that seroprevalence rate was already 76%, much higher than what we have in India. And now there is a second peak, which is much larger than the first peak, despite this 76% seroprevalence, and 40% of these cases are caused by the variant strain, raising the question whether this isolate can evade immunity. It of course has greater transmissibility. And already you've seen these results. Gagandeep has shown you that the Novavax and the Janssen vaccine have clearly shown that efficacy is lower with variants than with the wild type virus. So to summarize, where are we with the vaccine rollout in India? We are doing this primarily to reduce morbidity and mortality. We are following prioritization principles based on what the world is following. We have been able to do it very soon after the rest of the world did it. And I think that's something very positive, something that has not happened in our country. Generally, we have been several years behind the West. However, there appears to be vaccine hesitancy, which I believe is partly because of complacence brought on by the fact that the disease is decreasing and we think there is a high seroprevalence. However, Emergence of SARS coronavirus 2 variants, which have enhanced transmissibility, more often severe disease, and partial immune escape. I think we need to be cautious. We need to continue non-pharmacological interventions so that we can keep the disease in check and allow our economy to work. We, at least our healthcare workers, we need to take to vaccination so that we at least have partial protection that even these vaccines offer even against the variants. And we should be open at the global level, at the industry level, to the idea that the vaccines will have to be changed to incorporate the changes that have occurred in the variants, and possibly the future vaccines will be multivalent, containing not only proteins from the original strain, but also those from these variants. Thank you.